Good evening, everyone. Here Imran Abbas from Dubai. Again, we are live with another session. We are continuing this series of MGB, OAGB. We have started this series with Professor Robert Rutledge, and the end of this series will be with Professor Carbajo. And also at the end of this series, we will have sum up session, and we will try our best during this series. So we will conclude all the discussion. And today it is a great honor. So this is great honor for me to interview such a great person and also such a prestigious figure, Professor Weiner from Germany. And really, I was excited to interview such a prestigious personality, such a prestigious figure. He's legend of surgery. He's real live legend. And again, it is great honor. Sir, so much thanks to accept our invitation. Sir, please, over to you, sir.
Thank you very much, Imran Abbas, for the invitation. And I'm happy to be here and to give my experiences of more than 4 decades of bariatric surgery. And we have many options to discuss or many questions. We should know that we are looking for the best treatment of our patients, and we know we will never have the best procedure, but the development of MGB and one anastomosis gastric bypass seems to be a great benefit to have an option for many patients to solve the problems that your patient has with obesity and with the comorbidities. And this is a topic that we have to talk this evening.
Sir, thank you, sir. Sir, because we have repeated questions, so this is because this is just interview in light mood. This is not like a webinar. So most of viewers, so they want to know about you. So, sir, your brief introduction, please.
I will maybe have a short lecture. I will show some slides showing my experiences. So I started in the 70s. I started with a bariatric procedure, and maybe nobody can remember. In the history, we had all the things that we have developed in the beginning was a trial to help these patients. And I started in the 70s. This in the year was the name or the term metabolic surgery was created by Henry Buchwald. I was not aware about his book at this time. We learned just the trials at this time, the 70s. We have done the intestinal bypass surgeries in a small series, also in Germany. And I made the first investigations about intestinal absorption and adaptation of intestinal absorption. And this picture shows Henry Buchwald some years ago. I was able to hand over the award of the British Journal of Surgery for his study of the post-study. The post-study was an intestinal bypass surgery to cure special diseases by intestinal surgery. This was the familiar hypertriglyceridemia. And he has shown 30 years later on that patients had the surgery, they survived. And the patient had in the same family, we had no surgery, they died. And this was a great start. Now we know everything what we are doing, especially in the MGB and one anastomosis bypass. This is metabolic surgery. And in this procedure, especially, we have many of these influences of the metabolic surgery. Just a moment. The next is just my typical case mix disclosure. You see, I have done also primary open procedures only in between 77 and 88. Only a small number, but I have done personally was only 6 cases of intestinal bypass and 34 vertical banded gastroplasties, open in a Mason or in a McLean technique. And then I stopped because this type of surgery was very heavy work and had also many of complications. We saw many of the BBG patients, 50% had a weight regain, they had a so-called stapler disruption, and another 50% they had a stenosis. So we stopped this, and I started again in 1994, and between with the gastric banding. I learned it in 1993 from Mitiku Pelachev in Belgium. And during this period, from 1994 until 1999, I performed only gastric banding. And then I moved to another hospital, became head of my own department, and I was able to start with the gastric bypass surgery, with a dual switch, with a sleeve, with a PBD. And in the year 2004, were the first cases of MGB. So, and all the other procedures, I tried everything. But finally, you see there are differences. I will show you later on also what regarding mortality and operating time. I was able some days to perform 2 cases of a total laparoscopic dual switch per day. But at the end of the day, you was really down because this is a very complex procedure. With the MGB, you can do so much procedures as you can. You can perform 7 or 8 procedures a day. This is just the difference what we learned. So we will have a special talk later on about a discussion about GERD problems and cancer. This is a main concern of some people who are against MGB. And I will repeat it again and again. We have the key point to prevent GERD and cancer in MGB is just to perform the procedure properly. This means a long calibrated gastric tube, which should be more than 12 centimeters long. And the starting point is the antrum, not the angulus or the incisura. No, it's a starting point is the antrum. And a wide anastomosis to have a good drainage of the low pressure gastric sleeve. This I will repeat again and again. These are the key points, what we have learned. This picture is from a publication from Mario Musella. Everybody knows him from Naples, from University Federico II, and shows the differences between the old Masons loop bypass. This name is very common still in Germany. On the right side, the Mirror 2, and on the left side, the MGB OAGB. And I tell you, this drawing shows not the perfect MGB and OAGB. The gastric sleeve is too short, and the distance what you have between the esophagus and the anastomosis, it's maybe 5 or 6 centimeters. This way should be here to have it longer, and the anastomosis should be here. The anastomosis should be below the transverse colon, very down and far away from the esophagus. This is one of the key points. And you saw another mistake. If you're looking above, you see. We know that Robert Rogers said, "Oh, it doesn't matter. You can go just up and not." Yeah, it's correct. Not too close to the esophagus, but left fundus, a large fundus in place. What we have, especially in this area, after, for example, after sleep or after gastric banding, this causes also problems because you have too much acid production, and then you have the problem of ulcerations. So the sleeve should be done very probably long and narrow, and a wide anastomosis. Not as this just in contrast to Roux-en-Y gastric bypass. Roux-en-Y, we should have a small anastomosis to have so-called restriction. This is not a way here. We need a good passage. And if the bile comes always into this area, but if it's wide, it goes always rapidly down and you have no bile gastritis in this area. So look, if you fix it before, you see this is a very, very good place. You see the transverse colon and the anastomosis should be below. This is from a publication in a long white anastomosis with a 6 centimeter long device. This is the best option to prevent all the problems. If you look at these pictures, this is the same stapling machine. Now you see it's above the insula ingularis. It's like a Roux-en-Y gastric bypass. And you have this short. This is a mistake. And this will cause a lot of problems. And finally, this patient should be converted after 1-2 years to a Roux-en-Y or so-called diverted MGB. This is a mistake. And the mistake is also the small anastomosis. This is a bile gastritis on the left side. Red inflammation caused by bile. And it's very small. It's not a stenotic by inflammation. It's primarily too small. And the bile comes in and the bile will not go easily out. This is what we learn. If you have the same extremely wide anastomosis, like in this case, it's also an MGB. Yeah, and maybe you can see also the bile is coming, but there's no bile in a gastric pouch. You need a wide anastomosis. So all the things we have in the consensus statements, this was published also the IFSO consensus conference. I was also the member of this consensus groups, and you can read the stage of 2000, what we learned in the year 2000, but we have to learn more and more. So we have maybe one message is bile in the distal stomach, this is normal. In 26% of all of our patients doing normal upper endoscopy prior surgery, also my case, maybe I will do an upper endoscopy by myself. I have done that 5 years ago, and I was a small duodeno-gastral bile reflux. But this is normal. After sleeve gastrectomy, up to 40% of all the patient has bile. The bile in the stomach is no problem. It's only just the question is, what is the volume of the bile? If you have too much bile and standing a longer time in a gastric pouch, then you will have a bile gastritis, and the bile gastritis makes pain, and maybe it's risk point. The next,
Sir, if it is possible, so you can stop sharing.
Yes.
Then we will go ahead because we will have some. So really, it was amazing. So you are this colorful slide that you have showed. You have started your bariatric journey in late 70s. Now about 4 decades. So in my opinion, today it will be great honor for myself, and I will learn a lot. So, sir, so when and why you have started MGB? What happened? You have started.
The MGB, first was a publication from Robert Rutledge about the first 1,200 cases. This was interesting, and I read this paper, and it was not the idea to perform this procedure, but in Germany, in our hospital in Frankfurt, the mean BMI at this time was around 58. And in patients with the BMI 60, 70 and more, the Roux-en-Y gastric bypass was the standard. And it was extremely difficult to perform this, some patients, the second anastomosis. In one case, I said, okay, it's too complicated, there's no space. So I make a pouch longer, like this in this publication. I make a longer pouch, and I like to move up the limb. And the limb was easy to move up. I fix the limb and make one anastomosis. This was a starting point. We had a small series, and finally we have done this not in a best way. because the pouch length was around 7 or 10 centimeters. Now you can achieve up to 18 centimeters if you know how to perform. But at this time, in 2004, nobody has an idea to cut into the antrum. And also the cutting machine at this time, the stapling cartridges was not so high. It came later on with the black cartridges. This came in 2008, 2009, was not available. And so as a risk point to cut the antrum. So we just made it shorter and we learned. And I went to Manuel, to Malaga, Caballero, and learned then his special small sleeve, but with a lot of anti-reflux stitches. And we have done in the same way. Finally, we made a Rudolf a CT investigations. And we saw this has no influence where the food will go in which direction. Finally, we stopped because this is very time consuming and sometimes all the risk points, to bring up the limb so high. So we stopped this after 1 year and came back to another technique. So we changed our technique. And since 2018, we have completely Robert Blatchich technique, but calibrated. So he's doing sometimes without calibration. We are doing calibration and make it long and tight.
Sir, excellent. Sir, during this period, now about 2 decades, you are doing this MGB. So during this period, as you have mentioned, you have changed also some parts or some technique of this MGB. So what is my question? So definitely you have mentioned, so this length of pouch, yes, at that time, so this was short and now this is more maximum length of the pouch. And as well as you have mentioned this gastrojejunostomy, that is the wide as compared to before. And also you have showed earlier, so this how you do this side to side this gastrojejunostomy. So what is now my question? If you compare now in 2021 as compared to that time, then you have started, so which complication or side effects of MGB that you have faced at that time, now there is no more that side effects due to changing this technique, like gastric reflux, any bile reflux, I don't know, dumping, I don't know what you want to ask about those side effects or complication of MGB that you have faced 10 years ago, 12 years ago, but progressively with the changing of technique, now much better results.
As we'll start with a problem of malnutrition or malabsorption. We had only 3 cases because I've never extended more than 200 centimeters of pancreatic limb. And these 3 cases I have to reoperate. I measured again and it was a mistake in the measuring. But finally, what I learned, I have done 2 of these 3 cases I have done by myself. And this time I was measuring in steps of 5 centimeters. I changed it to steps of 10 centimeters because the mistake what you can achieve is much smaller. And in this case, at 200 centimeters, I believed it was 200. No, it was not 200, it was 270. And the common channel was too short, it was 240. So therefore, if you do a longer limb, more than 150, you have to measure the whole length. So this plays no role in our experience. Malnutrition is extremely rare and is mostly a mistake of a surgeon. The second point is what we have seen in the beginning with ulcerations, bleeding, perforations, such things. This is we have to learn, or we learned, never do a smoker. You have to test the patients very early and very tough that they are not smoking. Smokers, this is only in the year 2018, 86% of my primary procedures have been MGBs. And the resting amount was sleeve. And the sleeve was just in patients for or after organ transplantation, for example, liver transplantation, kidney or heart transplantation, or smokers. Or maybe it was a Crohn's disease. This is the only indication not to perform an MGB. And maybe also it's not an absolute contraindication for Crohn's disease. Nobody can expect where the Crohn area what will happen. But this we learned, and what's the main problem what we saw is the combination of acid and bile. So if you have a large gastric pouch or a large gastric volume, you had a really good acid production, and the combination with bile, you can have ulceration. So finally, we have make a small gastric pouch or gastric surface, only on a lesser curvature. And we added also a PPI medication after surgery for the first half year. And since then, we had never seen any perforations, or mostly of the perforation has been for smokers. And then we had done 157 cases, switched from MGB to Roux-en-Y gastric bypass. And I can show you the data. Now we are looking, we will publish this data maybe in 2 or 3 months, looking for all the results. Most of these patients had a previous surgery, bending or sleeve before. And we have done many mistakes with the sleeve. And it's a good idea if the patient has a sleeve and the patient has reflux, or the patient has weight regain, or both, to perform MGB. It can solve all the problems, but is a wrong way to just horizontal to divide the sleeve and to add the limb. You have to do the same. You have to resize the sleeve and make it also calibrated again as a primary MGB, and make it on the lowest point, far away from the junction. This have many mistakes what we have done. And then I looked also for the experience from the surgeon. Under my guidance, many surgeons learned bariatric surgery. And then I looked for the first primary procedure. What was experience at this time? He has done 10 cases, 50 cases, or 100 cases, especially in MGB. And if somebody was not so experienced in the beginning, you can have some more mistakes. If you have done you have the experience of 100 or more cases, and you know the key points, the frequency of reoperation. I have done for my patient only just 2 with the bile reflux symptoms. I made a longer decision and discussed not severe problems. I said, okay, it's better in this case, maybe we make a conversion or diverted MGB, but this is be rare. This is dependent from the technique.
Sir, thank you. Sir, another thing, so you know better than me. So the main concern, so because you are pioneer of bariatric surgery in the world, one of the pioneer. So in many meetings and different meetings internationally, always we hear, so these concern, the main concern of MGB is this bile reflux, not acid reflux to esophagus. That's always they ask, and also marginal ulcer. So now in 2021, is this concern is real or no? With the passage of time, with technique, with using this PPI for 6 months, with diet protocol, so there is this concern has no space.
It's a long discussion. In 2011, where I have this shirt here
Yeah,
from
yeah.
the Hamburg meeting, I had the idea, bring all the experts together, and the first plenary session, I created the first plenary session with a discussion MGB versus Roux-en-Y gastric bypass. And the discussion was between Robert Rutledge and Jean-Marc Chevalier and Michel Suter and Alan Whitgrove. Yeah. And this discussion was, some people are against, like Eric De Maria or something. You can talk, you can show what you will. We have their own experience. Maybe from the beginning we have right. The older procedures have been different. But now with the Helicobacter eradication, with aftercare, with PPI, and the technical points that we discussed, is this procedure a safe one with the lowest morbidity and the lowest mortality? And it's also a fast and safe procedure. There's only one anastomosis. You can reverse it. I reversed also 2 cases, but it was a special the patient with, another was a cancer situation. It's easy to reverse, and it's easy also to adapt. If you believe that the patients have performed many procedures also in lower BMI for diabetes, just with 120 centimeters biliopancreal limb. And if you feel it's not enough or it's too much, it's easy to convert. Just cut the junction and make a new one. Yeah. There's no procedure you can change. And I'm strongly against all duodenum dividing procedures. Nobody will reconstruct a duodenal switch or a SADI.
Yeah.
This makes a difference.
Yeah, sir. So regarding this, you have also mentioned in your just now in your discussion, because this is a question. So regarding this upper endoscopy and H. pylori eradication, is your routine? This?
First of all, we are happy that we have our own department for bariatric endoscopy in our own clinic. And the upper endoscopy is done by the bariatric surgeons before and after. So I have control of all my patients after sleeve and after MGB, 1 year after. And depend from the findings, I give the recommendation, everything is fine. And then I give the recommendation to have it after 7 years again. But before, you need a really good investigation and you need a Helicobacter test. And in case of infection, you need eradication because the remnant stomach will exist in both. And the higher risk for cancer, you have in a RNYGB gastric bypass, not in the MGB. Because the duodeno-gastral reflux that you have before surgery and will continue also after surgery, it's very easily undisturbed in the RNYGB gastric bypass. In the MGB, you have the small channel, and the smaller part for bile. But this can cause chronic pain. I remember for cases, and also in literature you find cases where have removed the remnant stomach just for cancer, early cancer, also for chronic bile gastritis, because the patient has chronic pain. Yeah? And this is absolutely necessary.
Thank you. Sir, regarding this post-op, also this surveillance endoscopy, what is your protocol after MGB? Is it routine and with which after 6 months, after 1 year, what is your protocol?
For my patients, for my protocol is to have it for everybody 1 year after MGB and sleep. I'm not doing this after RNYGB gastric bypass because this was a major group before. I have done 3,470 RNYGB gastric bypass. I'm not able to follow up all these patients. The MGB patients, I take care and we give the recommendation for the sleeve patients to have at least after 7 years a control. We have never seen such a high incidence of Barrett's, what is described by Genku or by Felsenreich from Austria. We have seen some cases, and but it's not a really common problem, in my experience.
Yeah. Sir, excellent. So what was your finding? So because now, as you have mentioned, since 2018, more than 80% your practice is MGB, and so this is now more than 1 decade. So you are doing MGB, and your protocol is endoscopy after surgery, MGB every year, after 1 year. So what was your finding?
After 1 year.
After 1 year. Sir, what was your finding? So what you see in these cases, marginal ulcer, gastritis, so what was your main finding? So just like this, some patients, they have they are symptomatic. Okay, we will do endoscopy and there is a marginal ulcer. Okay, we expect, yes, this case will have marginal ulcer. Have you faced silent marginal ulcer in these cases?
No, no, sorry, sorry,
No.
no. I just my main focus is to see what is going. It's any symptoms for GERD. It's a Barrett seen. It's a gastritis is seen, and how it looks at anastomosis. Yeah, and sometimes you see in patients, if you're taking aggressive medication or so, you see sometimes in the area of anastomosis, small irritations, and this can be treated by reduction of acid. Uh,
Yeah,
this
sure.
is mainly caused by acid, but you must be sure that the gastric pouch is very tiny and there's not too much acid production possible.
Okay.
Otherwise, you have to continue the PPI medication. But
Okay.
silent ulcerations, I haven't seen.
Never seen. Sir, regarding GIRD and MGB, so this is just your experience. I want to hear from your side a symptomatic documented reflux. Patient has symptoms. Your
Um,
endoscopist confirm this. Are you go for MGB in such a case?
um, if you have everybody can receive during the follow-up control the questionnaires regarding quality of life control with reflux symptoms. Yeah, and if the score goes over 9, you have to look more at something behind. And we recommend in these cases an upper endoscopy, but it's not all the time bile the problem. Yeah. One third is bile, one third is bile and acid, and one third you find nothing. This is a problem. We stopped with all the. It's very difficult to have a biometry for 24 hours or so. We stopped this. If you have bile in the upper part in the esophagus, it's clear. And the patient described you have a bitter taste. But these cases are rare. I remember in the last years two of them. We had a primary procedure. The patients with a sleeve before, we have mainly the problems of acid, and sometimes because the sleeve is too short. Yeah, because what was the technique in this case is you have a sleeve, the antrum was still mostly in place, or the antrum was enlarged. So and then it start at in the sura the sleeve. And this was the point for dividing the stomach. And this is too short. So if you do after a sleeve, you have to start again with the antrum. You have to perform an antrum resection as a resizing of the gastric tube. This is what we have learned, and for the future, the recommendation is never just to cut the sleeve and to add the limb. You have to create a new gastric long sleeve.
Sir,
And
excellent.
to
Yeah, yeah, I agree. Sir, no, what is now my question? Patient is primary patient, not redo surgery. Primary case with GIRD, with symptomatic reflux, that most probably this is acid reflux, not bile reflux. And also your endoscopist confirm, yes, this is esophagitis, and also there is a acid reflux. This is primary surgery, not redo surgery. Have you done MGB in such a case, suffering with esophagitis before surgery, and what
yes,
was the
yes.
result?
If you have a DIRT as a Los Angeles classification A, maybe also B, and you perform an MGB, you have an improvement of the reflux symptoms. It's in the majority of the patient, you have an improvement because this is a low pressure system. And you have a wide anastomosis, it goes only just in one direction and not back up. Not this is the only my concern is, and this is only just theoretically, is a patient with a Barrett. In the Barrett case of a Barrett, I will prefer Roux-en-Y reconstruction, but the limb length is the same like MGB. I make a longer biopancreatic limb and 70 centimeters alimentary. So this is like we is doing the so-called diverted MGB. But the diverted MGB is, is
Excellent.
it's
Sir, because you know better, so so this is one of the treatment of GE reflux is fundoplication in low BMI cases. So when we confirm, yes, this is a gastroesophageal reflux, the treatment of gastroesophageal reflux in low BMI fundoplication. But in morbid obese cases, the gold standard is Roux-en-Y gastric bypass. So
yeah.
are you think in future, so maybe this MGB will replace Roux-en-Y for the treatment of this gastroesophageal reflux in morbid obese patients?
I'm not sure if it will replace, but maybe it has the same importance. If somebody, many surgeons, they have they prefer the MGB, and if you decide also in reflux patient to perform MGB, it's okay. The problem is you said a low BMI and morbid obesity. This is not a good classification. If the patient comes with a BMI above 29,
Yes.
no, 30, with 30,
Yeah.
I will not recommend a fundoplication.
Yeah.
I recommend a gastric bypass, not treatment for this obesity class 1 to treat reflux and prevent morbid obesity. But the name morbid obesity is an old one because obesity it's a disease, and it starts with a BMI of 30 or whatever. It's a disease. As a chronic inflammation, all the diseases coming. So why I will not do perform a fundoplication in higher BMI as over 30? Too high abdominal pressure in the abdominal cavity in obese patient, and this is a high recurrence rate for complications of fundoplication. Here the plastic goes up. You have to perform a rhinoplasty. The wrap is moving up into the chest. You have a wrap migration. This can prevent. Do it only just fundoplication, only just be up to BMI 29. My recommendation is BMI 30. Bypass, in general, bypass surgery as an option. You have to just to adapt the limb leg.
Thank you, sir. Sir, regarding this redo surgery, so if some patient, so you are going to revise a sleeve gastrectomy due to intractable GERD. Patient is suffering with the reflux and really this is intractable, no response to, and also when you evaluate this patient, so there is also migration of this gastric pouch inside this mediastinum. So inside also you confirm, yes, there is no kink and no stricture at incisura, and there is no twist of sleeve. Everything is okay downside, but this is a migration and patient is suffering with GERD. So have you done MGB in such a case in your experience?
Yes, we have done, but all the time, if you have a sleeve migration into the chest, into the mediastinum, you have to bring it down.
Yeah.
Otherwise, it goes the drawing of the esophagus. It's like it goes all the time. The power goes up and is moving more and more. But you have to bring it down and to close the diaphragm. But the hydroplasty itself is no anti-reflux procedure. And maybe you have to fix the sleeve on the left cruise. But finally, far away from this, make it in a low pressure system with a wide anastomosis, and then everything goes in one direction, not up.
Excellent, sir. Sir, if you have any slides, please, sir. We want to.
I
Yeah,
will just go back
sure,
to
sir. Sure.
one discussion about cancer. So this is what we learned by many publications. What I just say, when the Helicobacter in pylori infection has more impact on cancer than the bile in the stomach. So this picture shows the early cancer in the remnant stomach. This is a rare picture, but you have to make a eradication in all cases just to prevent this development of cancer in remnant. And maybe look for Mario Marcella's publication about the cancers after gastric surgery. You see, 3 of 4 cancers are in the remnant stomach. It's not a question that you have the cancer in the gastric pouch or anastomosis. The anastomosis cancer is typical in a cancer surgery. After bariatric surgery, after gastric bypass, most of all cancers are in the remnant. Therefore, this is very important to make it directly. And sorry. So, and message 3 is if you have high volume of bile in the stomach, this causes problems. This is only just if you have such a small hole like this. It's not the stenosis, not secondary. It was a primary small anastomosis. The bile comes in and is not able to go out fast. So it comes more bile in than out. This is a chronic inflammation, and this makes also chronic abdominal pain with a remnant in the remnant stomach. The same procedure, not only just bile into the gastric pouch, you have also the same problems in the remnant, and you can have. I will just show you later on how you can detect this. Yeah, so small amounts of bile in the distal stomach is completely normal, and also only just larger amounts are causing bile gastritis. Yeah, this is very, very. But you know, the bile is also our friend, especially in the MGB. The bile has a special role because in a longer pancreatic limb, we have the reabsorption of the bile. Now the bile is produced in the liver, goes in a duodenum and comes in a longer limb, it will be reabsorbed. And then we met the nutritions. Most of the bile is reabsorbed before. Therefore, we have all the malabsorption. And not only just for fat, because bile is necessary for all processes of intestinal absorption. I published in 1984 a book. This is called enteral resorption. This is in German. It means intestinal absorption. I look for patients with jaundice. If you have a cancer patient with jaundice, with a bilirubin over 20, and they become very fast slim and they died very fast. This is because we are not able to absorb active glucose, amino acid, nothing. And this is the principle also of the MGB, that the bile is reabsorbed and you have a totally impaired absorption of everything. So just the message is clear: in the bile, esophagus is a cancerous. Yes, we know the data from the sleeve gastrectomy, 17%. I have never seen such a high incidence. In our sleeve patient, it's less than 2%. And I'm just showing the bile and the remnant, just to show. Then you have to do a gastrectomy. We have done also. This shows the picture with technetium isotopes. Yeah, you see it's produced in the liver. On A, you see the concentration on the right side in the gallbladder. Yeah, and it goes into the duodenum, and you see in the remnant on the right side B. It's now in the remnant stomach. The bile is in the remnant stomach, concentrated. In this case, when the patient has chronic pain, you know, the bile is a cause. In this case, the patient is suffering a lot. You have to remove the remnant stomach. So we have done this in the primary procedures, the RNYGB in 6 cases, and but we've never done this in the MGB. Never done in MGB, only just after RNYGB bypass. Just regarding back to 2011 to the World Congress in Hamburg, there was an analysis of 2011 about the risk, the mortality of different procedures. At this time, we had a mortality in the duodenal switch, 1.4%, in the sleeve, 0.4%, in the Roux-en-Y gastric bypass, also very low, but it was 0 for MGB. And between 2011 and 2021, the next decade, we never lost a patient with the MGB. Only just one case. This is maybe important to know. The patient came from Kuwait and had a MGB. It was an older lady, and after 3 or 4 years, she had another disease and need artificial nutrition, enteral nutrition, and the surgeon or the doctors there placed a feeding tube, and now finally we know this after from the pathologist, we placed it into the afferent limb, in the pancreatic limb, and make an artificial nutrition. Yeah, and the limb dilated liters of nutrition moved or was standing, and then she vomited heavy and had the aspiration. Finally, she died. So it's very important in this case to know that everybody should know if you place an enteral feeding tube after MGB is completely different from normal person and Roux-en-Y gastric bypass. If you place the feeding tube in the wrong direction, it's dangerous. Yeah, it's a rare situation. The lady was 74 years, had a cancer disease, but it just to know for somebody else, if you do an enteral nutrition and also make a control, you can place some contrast medium via the nasogastric tube and believe, okay, it's in the intestine. But if it's the wrong limb, it's a real problem. Finally, she died in this situation. Now, we know also less internal hernias. We had some cases of rotations, but the anastomosis rotated. This is like a twisting, and had other several heavy symptoms of the patient. This is a picture shows a typical Roux-en-Y gastric bypass Peterson hernia. This will never happen. So we have no reports about necrosis, intestinal necrosis after the MGB, and the situation of rotation is much less. So just summarize the positive effects versus Roux-en-Y. You have a better weight loss. In our experience, it's faster. This time was 34 minutes versus 54. No complication of enteral anastomosis. It's only just one anastomosis. No weight regain. I cannot remember patients with weight regain. Where you can adapt better. We have some cases we stopped the weight loss before they reached the goal, and we had a nutritional consultation. And with this procedure, you can. This is a difference to Roux-en-Y. You can explain how to eat, and do not avoid fat, but you have to have not too much carbohydrates, not too much wheat, and less internal. And I have never seen such a severe dumping syndrome like we know is from the Roux-en-Y gastric bypass, because the distal so just this mistake from the conversion of MGB to Roux-en-Y in this years, and this was one of the 14 cases with after sleeve. In most cases, we have done just this short gastric pouch after sleeve, and this convert. This is a mistake. We have to learn. If you do it, then you have to do it starting again, starting a new sleeve on a middle point between pylorus and antrum, and start again with the calibration and to resect the antrum. This is the only way what we learned just now. So you see, you never stop learning.
Yeah. Sir, excellent presentation. So I have one comment regarding that feeding tube that was in efferent limb. So we can put this feeding tube in stomach, that remnant. So that will be a gastrostomy. So we can put this feeding tube inside that part of stomach, and then we can feed the patient. So sir, my question regarding hiatal hernia. So what is your opinion about hiatal hernia before surgery? If you diagnose large size hiatal hernia. So, what will be your protocol, or have you done any MGB in such a case, and what you did?
I cannot really remember, but I have done simultaneously a large number of hiatoplasties. If you have somebody who has a hernia of 2 or 3 or 4 centimeters, doesn't matter. Only just paraesophageal hernias should be closed because they are risky. If you have, for example, we have done also MGBs in cases after upside down stomach. Yeah. Patient coming with upside down stomach, we have obesity, and finally you have to bring down the stomach in the abdominal cavity, and then the question, what do you do? Will I do a sleeve, or I do a MGB or RNY? So I was against the sleeve because the sleeve will move very fast again up into the chest because longer existing upside down stomach, you have a shortened esophagus, and this all the time will draw up the sleeve maybe back again. The idea is, if you perform a bypass with all the weight of the limb, you add also the intestine, and in the standing position all the time, it draws down. It's a good option, and you have a guarantee of weight loss. So I've done some cases upside down stomach in the same procedure, MGB as a bariatric procedure.
Thank you, sir. Sir, as you have mentioned earlier, so regarding this BP limb, now your BP limb is less than 200, and also you have started to measure 5 centimeter, not 10 centimeter. Maybe at that time this measurement was not correct. So in earlier stages, have you faced severe malnutrition?
Sorry, I never have done 5 centimeters pouch length.
No, no, no. Measurement of small bowel.
Sorry, steps, step doing measuring, yeah.
Yeah, yeah.
I prefer to make it 10 centimeters, 10 centimeters, 10 centimeters.
That was, yeah, sometimes, so it was wrong and it was more than 200 centimeter. So what is
Yes.
my question? My question is regarding severe malnutrition after MGB. So what you did, especially in those cases that was suffering with malnutrition, because why I am asking this question, now we have about 1000 viewers live. Now I am watching in Facebook, and so most of them, there are youngsters, they want to know about this. These are key points. If someone, so patient is suffering with malnutrition and now need, how you treat these cases. So just like you will start with feeding tube, so because patient is not now stable, we cannot do surgery. So we can, what is your protocol, sir? How you, first of all, how you stabilize this patient, and then when patient will be stabilized, so which surgery, this is, what is your preference in such a case?
If the patient has real malnutrition, especially protein malnutrition, then we have a concept of refeeding, gastric refeeding. This is a publication. We published these cases under the name of Sonia Chiappetta. She's now in Naples, but we published this data, refeeding before any surgery. But this special 3 cases were not necessary. One of these cases was a student, and he had a severe disease of psoriasis, and he was treated with methotrexate very aggressively, and he was suffering grief. And I talked with Robert Luttrich, was in our hospital at this time. The patient came back with this severe malnutrition, and he believed it's only the question of good nutrition. And he explained him again how to eat, what to eat, and so on. But Robert takes a long time with the patient, talked 1 hour, him explained everything, how to eat, but it has no influence. But the background was, I believed he has a bilipancreal limb of 200. But this was not true. This was a case with 270 and a Kamenschell of 240. So I performed just, I cut it, the anastomosis, measured again, and then I was surprised, and I make a 150 centimeters. The recovery takes a longer period. Yeah, maybe the reconstruction to normal stomach, and later on they have a second surgery again. It was another option, but finally he needs a half year to overcome this malnutrition. But finally everything was good, but with the MGB of 150.
Excellent, excellent, sir. Sir, already you have mentioned regarding this marginal ulcers, because you have never now find, especially after MGB, but in earlier cases. So that was after sleeve gastrectomy or redo surgeries. In such a case, and also there was short gastric pouch. So in such a cases, yes, you have faced marginal ulcers or some GERD in those cases, and you have changed all of these cases to Roux-en-Y gastric bypass.
Yes.
So if we face, so what is my question? If someone faced marginal ulcer in normal MGB, normal, so this is a long pouch, this is not short pouch, and patient is suffering with marginal ulcer. So what is your suggestion and in such a case?
Yeah. What we have learned in the years of before 2014, we have done only just the PPI medication for 3 months after surgery, also after Roux-en-Y, after MGB, after all procedures. And then we saw some cases of marginal ulcers. We extended the time for 6 months totally, and then we stopped. And it's surprising, the number of ulcerations and such complications dropped down remarkable. So to have a half year or maybe 1 year PPI medication after gastric surgery and after bypass surgery, Roux-en-Y, MGB, whatever, it's a time to adapt the gastric mucosa, whatever. After such a period of 6 months, PPI medication, you have extremely less, except smokers. If you have a patient will come with a gastric perforation after MGB or after Roux-en-Y, you know it's 90% it's a smoker.
So, sir, it means you never go MGB for a smoker. You are very strict.
No, very strict. And the best way will be, but this is not possible. We are asking the patient, but you know the patient are very good connected in social media, and I like to have an MGB, I like to have a Roux-en-Y gastric bypass, but don't tell the doctor that you're smoking. So we're lying. Maybe you need a heart analysis. We have not done so, but maybe it's the only way to accept to have no smokers for any bypass surgery, gastric bypass, independent, MGB, Roux-en-Y, whatever. All the problems are the smokers.
Sir, if someone is smoker and also he's willing, yes, he will stop smoking. How
No,
long time is sufficient?
Yeah. You come in the hospital, it's just smoking. Maybe you see the patient standing outside in front of the hospital, the last cigarette, and then they come in and say, you can smell it. You have to say, okay, it's not the time. You have not to operate. If you're doing the patient, just here, or you're looking for the money of the patient, whatever, this is a mistake. If you know and you saw and you smell he's smoking, stop this. All the time you have problems with the patient, and you will not. He comes again with problems. You have patients that have upper endoscopies done 15, 20 times. Coming, going. This is disaster.
Yeah, I agree, sir. Sir, we have also some questions from our viewers. So one of our viewers has question regarding multivitamins. How long time you prefer multivitamins for your patients?
Yeah, lifelong. All the treatment is not a medication. It's a supplementation. With these patients, we recommend lifelong. And this makes not only just multivitamin, you need especially vitamin D3 in combination with calcium. We recommend also vitamin B12. And the most common, but you know what we are seeing, we make a lab control, everything is fine. We are the only two things we are never, the most concern after MGB is you have a lower vitamin A level and extremely often vitamin K, K1, K2. And this is just not, there are some medication from some companies, we specialized on for MGB supplements, yeah, for example, Fit for Me or these companies. Then you have also a little bit of vitamin K and such things inside. Otherwise, you need a control. And if the vitamin K is lower, then you have to add this vitamin, the quinaquion, yeah, to add this. These two are the most common deficiencies, K and A, because they are fat soluble. And this is a main problem of this procedure, not in RNY, especially in the longer peripunctal limb leg, also like doing the switch.
Yeah. Thank you, sir. Sir, regarding because you have a wide experience of malabsorptive or hypoabsorptive procedures. So one of the complication of malabsorptive procedure is nisidoblastosis. So this hypoglycemia after such a surgery, have you faced after MGB?
Not such heavy cases, and it's a different types, especially when you have at night so low blood sugar. What we have seen in the beginning is more the vasomotoric dumping, because the vasomotoric, this means your patients are sweating,
Yeah.
have some discomfort because the ilium, the distal, is like the PPD. The PPD has the first lymph node the nutrients are going in is a ilium, the distal, and this is reacting vasomotoric. This is the difference to Roux-en-Y with the jejunum. The jejunum has more influence of regulation of the blood sugar regulation, especially in the so-called late dumping, which comes after several hours with a extremely low. We have done all these cases with a chip measurement, 24 hours. The blood sugar levels, we saw some of the Roux-en-Y patients also after sleep. We saw a patient, we had a extremely low of 25 milligram sugar at night. Yeah, this is a disaster.
Sir, regarding this, so this is dumping because you have mentioned. So, have you faced any case that was intractable dumping? So, because
Not,
you are,
not,
no,
not,
okay,
not an MGB, not an MGB. Sorry, not an MGB.
never you faced so this dumping. So, because you are, because what was my why I am asking this question? Because we have discussed in different professors. So, what was my question regarding this gastrojejunostomy size? Now your gastrojejunostomy size is 6 centimeter, so easy, yes, and wide. So their concern was dumping. So now you are practically asking. So yes, there is no such a dumping, especially extremely dumping after this wide gastrojejunostomy.
Yeah, this is not, I'm using 6 centimeters or 60 millimeters stapling device. At the end point, the diameter is 4.5 centimeters. Yeah, 4.5. It's wide. In Roux-en-Y, I tried to create a 1.5 centimeters small anastomosis. And also in these cases, it's not dilated. You can see dumping, patients with dumping regulations. Because the upper, this glucose molecules goes in the upper jejunum, have another regulation as a distal. This is completely different.
Yeah, absolutely agree, sir. Sir, regarding so you are this post-op feeding. So this is also very important for us. So what is have you special protocol for your patients?
Yes, this is it's not real science behind. we have since a long time the preoperative protein-rich fluid diet 7 to 10 days prior surgery for every patient, because the liver becomes smaller. You have patient feeling better, and I have the experience also the recovery is faster. In my hospital, I was in Frankfurt. The next head of the department came from Switzerland. He said everybody can eat until the day of surgery, and he can start the same way on the next day. Okay, we do not doing so. The patient just after surgery has less hunger feeling, and what you need is just fluid. So we're starting to get continue during the hospital stay only just fluid nutrition, protein-rich yogurt and so on. And this will continue for 2 weeks, and then we're going up to smooth diet, protein-rich, and then the patient comes back after 1 month for control, and then he start to eat in a solid way. So you can do what you want. The end point of weight loss after 1 year is better if the patient has a diet before and a diet after. You see the difference. Yeah, the patient has a better result, a better understanding, and they understand that we change their life. And we have to avoid some nutrition, especially sugar, but not to learn that fat is a bad thing. Fat itself is good, just for MGB patients. Fat is a very important. It makes satiety. It has a good taste. Makes only satiety and will not be completely absorbed. Maybe then you have a looser stool and you have more flatulence. But this is a good thing. But it's easier to handle for the patient.
Thank you, sir. One of the earlier complication of MGB is bleeding, because we have too long sleeps, just like imagine in a patient. So, have you faced earlier bleeding after surgery?
We had some bleedings, like a sleeve and a long stapling line. I was using all the time buttress material. Lifelong, I was using all the time buttress material. And it is for sure that bleeding rate is low. And we placed more than 20 years, we placed a tube for 24 hours. Yeah, and let the patient staying in OR just after the surgery in the wake up room, and then we're doing the next surgery, and the patient goes, the next comes, and we're laying beside and looking. Is some a little bit idea there's a bleeding. Patient goes back in OR and has a real laparoscopy, not waiting, not discussing, not to make lab tests. And if you have some symptoms of bleeding, and it's maybe 6 times, 7 times a year, and then you'll be going back in OR, make a real laparoscopy very fast. In 50%, you will find the bleeding active, and you can stop it. Very small bleeding, pumping, make one suture, and 50% bleeding stopped. You feel just see the hematoma, and then you remove the hematoma. The patient recovery is much faster. So I believe not discussing too much, whatever. Blood oversewing or buttress material observation, and then you're on the safe side. I never lost a patient in my life with this bleeding in bariatric.
Sir, one of the opinion is this: so you can deflate abdomen completely, and you can sit, okay, 5 minutes, 10 minutes, you can wait, and then again inflate, because due to this gas inside abdomen, this inflammation, the pressure, so there is no bleeding. So are you agree with this opinion?
So
No need.
no, I will not again. First of all, I will lose too much time, and it this is what happened. Maybe at the end point, you have to talk with anesthesiologist. Please bring up the blood pressure up. We make it okay. So it's not bleeding, but the bleeding it starts because we are placing the tube. I'm leaving the OR and looking at the tube. Nothing's inside. Starting the next procedure, and after 1 hour, they're calling me. The number one, the first one is starting bleeding. So I believe it's a good idea here if you have enough time to deflate and to inflate again. But yeah, maybe it helps or maybe not.
Okay, sir. Sir, just maybe this will be second last question. So, any bitter experience in MGB and always it disturb you? Yes, this was something wrong, and so we can do better. Anything? You remember? No, you are more than about 2 decades doing MGB.
Yeah, yes, and I know um, all the time the patient, for example, has a previous surgery like an orthogastric bending, adjustable gastric bending, patient has a history of slippage, and then you have a problem to, especially obese patient can be BMI 60, 70, to be sure that you have divided the gastric sleeves. There's no bridge on the left cruise, and sometimes it's very difficult to be sure. And I have I remember 2 cases. Finally, I performed after 1 year an upper endoscopy, and I saw a hole. There was a bridge. There's not a gastric, so-called gastric fistula, but this was not a gastric fistula. The same what in the United States we're reporting in the beginning of worldwide, a lot of gastric fistula.
Yeah.
This was not completely divided. And okay, patient lost weight pretty good, and okay, not to hurry. Yeah? If the patient will stop with the weight loss and he reached not the goal, at this time he's slim, you can perform easily a second procedure and divide the bridge. Or sometimes after special banding and slippage, it's very difficult. So I'm using these instruments for introduction of the gastric band. You know, this special hook to go be a bit like a finger behind the stomach and to see there's no bridge anymore. These 2 cases finally was not able to make it completely. I had a bridge. Yeah.
Sir, yeah, excellent. Sir, any message for youngsters? So those who are now going to start MGB, what's your message for those?
Yeah, if you do it properly, so from my peer experience, it's extremely easier to perform this procedure, especially in patients with a large spleen, whatever, in comparison to sleeve. You have to go so close to cut the short gastric in front of the spleen. So if you go in MGB and you're looking all the time with the camera also in the bursa orbitalis, but if you see the spleen from behind, be very careful. Otherwise, you go with the stapling into the spleen and you can have a bleeding of the spleen in an area where you're not able to stop it. Yeah. So, but to be on the, I will prefer to use a calibration tube because all the time the calibration tube gives you an orientation about the anatomy, and you are sure you're not will damage the esophagus. So I had some patients came to me very completely divided gastric pouch with after sleeve, and also one case after MGB without any calibration. We cut
Yeah,
just
yeah,
and okay, in these cases we can solve the problem also laparoscopically, just to add a limb up to the esophagus. But you know this with a sleeve, it a sleeve-like pouch is a calibration group important, but it all can be dangerous because you have all the time to be in connection with the anesthesiologist. You must be sure that the tube is in place. And if you're cutting something, also tell them, oh, you are here, please take the tube and move it a little bit forward, a little bit back, and then you go ahead and have to be sure where is this. Because sometimes somebody, he get a call, the anesthesiologist, I had my own experience in the sleeve, he moved out and another came in, and during this period, the calibration tube went out and he pushed it again into the remnant stomach. And then I was cutting. Yeah? Yeah, you can feel it, you can hear it, then it's too late. Yeah. And I know many of the surgeons, also my daughter, he had the same experience. So this is very important to talk and to know where is the sleeve located, where's the calibration tube. This helps you very well.
Sir, really, it was a great session, and especially myself, I have learned a lot because you had a lot of experience, about 4 decade experience of bariatric surgery, and hopefully this will be very fruitful and definite, sir. We are making a history. This your video will be available also on GLR library, and also we will see viewers now also on YouTube channel, and also Facebook. More than 1000 are live now watching this video. Special thanks, sir, really respects. And also we will continue our series of sleeve gastrectomy, then Roux-en-Y, then for metabolic surgeries and redo. So till 2023 we have planned June 2023, and definite in other series also. We need your support, we need your guidance, sir. Special thanks, really thanks.
Yeah, thank you also very much.
Thanks a lot. Thanks a lot, sir. And also, my viewers, so thanks for your time. And next week, also, we will have another legend of surgery, and also as well as expert of this MGB, Professor Rui Rubirio from Portugal. And also, we will discuss in detail regarding his technique, especially regarding tailored BP limb. He has a lot of work about this, and we will discuss and must continue. We need your support also, especially your questions. That is very important. If you have any question, you can ask before also that interview, or
And,
also during live. Please, sir.
and you will see us all in Frankfurt meeting in November this year.
Sure, sir. Sure. Definite. Hopefully, at that time, there will be no COVID, and definite I will be there, sir. And also from your side, also an invitation to all viewers. Thanks a lot, sir. Have a nice time. Thank you, sir.
Bye-bye.
Thanks a lot.
Bye-bye.
Thank you,
Bye-bye.
sir.